My name is Brenda Nordstrom, and I am with Baker College School of Nursing, the Muskegon campus, and Lakeshore Human Trafficking Task Force. This is part 2 of a 2-part series on responding to human trafficking, which is a training for healthcare workers. So now let's look at human trafficking and healthcare. What does human trafficking look like for us who work in the healthcare industry? First of all, understand that human trafficking is a global health issue and a public health issue. For years, trafficking was looked at as simply a law enforcement issue, and those who work in law enforcement have been receiving some training on that. But in healthcare, we're finally coming to the realization that this is truly a public health issue. If you look at the risk factors of those who are in trafficking, you're looking at foodborne, airborne hazards, chemical hazards, accidents. They live in very unhygienic situations, poor nutrition, poor water. They get exposed to infectious as well as non-communicable diseases. They have occupational injuries and can become disabled due to those. Some of the global stories I hear involve even amputation, especially those who are out on fishing boats and whatnot. And in one study, nobody got help. They just tied off the end of the arm and they kept going. It's just horrific. Um, so more and more studies are trying to look at human trafficking as a public health issue. When it comes to working in the acute care setting, one study in particular looked at 106 survivors out of Minnesota, and 88% of those survivors interviewed said that they had sought health care while in captivity. Now, people are wondering why in the world would somebody allow a trafficked victim to get health care? If you are making money, say off your car, and that you're in some sort of transportation business, and that's how you make money is with the use of your car or your truck. Something goes wrong with that vehicle, you can no longer make money. So you take it in and you get it fixed. Traffickers do not allow their victims to get health care out of the goodness of their heart. They allow them to get health care so they can continue to make them money. If they're broken, they get them fixed. So that's why we do see them. So you'll see different numbers depending on which study you look at. Some say 25%. I've seen up to 88%. Locally, the HOPE project has said almost 100% of the women that they've interacted with have reported seeking health care. So we do know that they do go to the hospitals. And by far, the vast majority are seen in the hospital emergency department as well as in outpatient clinics. So before we get into the specifics, I'm going to walk you through 3 scenarios. And I want to see if you can identify a trafficked person who is presents to the healthcare setting. So for starters, we have a 33-year-old female in the emergency room. She is bleeding and covered in bruises. She has a broken finger that is so swollen she cannot remove her ring. In fact, that's the reason she comes to the emergency room, is to get that ring cut off because her hand is so swollen. It's causing severe pain. She states that she got drunk, had a fist fight with her roommate, a 27-year-old female who is with her in the emergency department. Scenario 2. We have a 19-year-old female comes to the hospital. She is going into labor with her first child. She's accompanied by 2 young adults, a female who is also pregnant, and a male who says he's the boyfriend and the baby's father. The female companion remains in the patient's room, is very supportive and helpful. The boyfriend frequently steps out of the room to speak on the phone and sometimes meets privately with other female visitors. Scenario 3, we have a 25-year-old female who is accompanied by law enforcement. She presents to a mental health facility. The officers explained that the patient originally presented to the emergency department and she claimed she was going crazy. Under direction from the emergency department, law enforcement brought her to the mental health facility. The patient admits to suicidal thoughts. She's hearing voices, but she can't remember what those voices say. Additionally, she says she has 2 children and that the father does visit but is not in the picture consistently. So, which one of these 3 is a human trafficking victim? If you guessed the patient in the second scenario, the pregnant woman in labor, you are correct. However, if you guessed the first or the third scenario, you are also correct. All 3 scenarios are based on actual interactions between a healthcare system and a survivor by the name of Wendy Barnes. In the first 2, she was the accompanying female. She said that in the first one, when she presented with her friend who had the broken finger and was all beat up, she did not have a scratch on her and was like 70 pounds lighter and shorter than the one who presented with the injuries. But nobody questioned the fact that that story didn't quite jive. The second scenario, they both were pregnant by the same gentleman who was their trafficker. And that is a very obvious scenario of a pimp or a trafficker and 2 of his female victims in an OB setting. In the third scenario, she had been brutally victimized in the home by her trafficker and then left the home to go out to make her nightly quota for money. And she had just about had it. She couldn't take it anymore and she needed to get away. And she presented to the ER as a mental health patient. And she did embellish the situation some far as hearing voices. She did have some suicide attempts during her time in captivity. And at that point, she was so beaten down psychologically, she truly believed that her children were better off with other people versus her. And in the mental health setting, nobody questioned why anyone would want to have themselves admitted to a mental health facility. That should have been a red flag to start looking deeper. Instead, she was questioned and not believed. She didn't come out and say she was a trafficking victim, but they told her, the nurse had told her that nobody has a life that bad that they need to lie in order to get a vacation away from their life. And so she left at that point. So, as indicated from some of those scenarios, reasons for seeking care. Again, the violence, the abuse, the injuries, pregnancy, sexually transmitted infections is a very big reason for coming in. Not all of the Johns don't wear condoms, and to have protection from the infections. And so they do get repeated infections and have to be treated for those. Drugs and alcohol, by far the vast majority of victims, especially sex traffic victims, do have drug and alcohol issues. Sometimes they are drugged by their traffickers and develop an addiction. Sometimes they came into the trafficking situation with a drug habit already in place and that drug habit is used in order to get control. The trafficker will feed their addiction and then start demanding pay for the drugs that they have given. As you can imagine, depression, anxiety, post-traumatic stress, and then of course chronic pain issues and headaches related to whatever type of work they're involved in, but also the abuse and the stress that goes along with that. Some red flags in the clinical setting. One thing, I'm going to give you several things to just kind of that should perk up your ears or open your eyes to say, hey, I need to look at this a little more closely. But every situation is different, which is why we can't get a validated tool that says if I see A, B, and C, then somebody is being trafficked. It is so varied in the types of people, the types of situations, the things that bring them into the healthcare setting that we can't do that. But what we're going to talk about are some things that should have you asking more questions and looking at the situation a little more closely. One of the main ones is having a companion that refuses to leave. They may or may not say anything. Sometimes they do speak for the victim, but they can also just have that very menacing presence standing at their shoulder, maybe even a little bit behind them, out of the way. But the victim knows that they had better not say anything out of line or they're going to pay for it later. So they're controlling in their mannerisms, if not verbally. And the person that's with them could be the trafficker, but it could also be someone called the bottom female when it comes to sex trafficking, because I guess in the hierarchy of the victims, somebody kind of gets elevated to the point where they are in control of the rest of the girls. And if any of the other girls get out of line, it's actually that bottom female that gets the abuse. And so they know that if they don't beat and control those that are underneath them, then they themselves will be abused. So many times in sex trafficking, it is the bottom female that accompanies the victim, but other times it is the trafficker. The victim comes in and they do not have control over anything. They may look to the person to make sure that what they're saying is appropriate. Their stories, their history of why they're at the hospital or the clinic just seems very mechanical. It's recited. It just doesn't flow. And in many ways, it's similar to a intimate partner violence situation. They come up with a story as to why they're there. Inconsistencies in their stories, very unclear, kind of vague. You'll notice there might be a prolonged lack of health care in that they have like their STI is like way out of control because they haven't been in to get it treated until it got so bad they couldn't work anymore. If it's labor trafficking, they could have injuries from on the job that weren't brought in, and so you might have old fractures that didn't heal right, or really bad scars, or cuts or burns that now have gotten to the point where they're infected or they need to be treated. But it could also be things like oral care. They just haven't been taken care of very well, very bad personal hygiene type issues. Subordinate, hypervigilant, very fearful. They're going to avoid eye contact. Many times they just want to hide and fade back and not bring attention to themselves. They just want their issue taken care of and they want to get out of there. You may see overdose or withdrawal symptoms. Like I said, many of the victims, especially in sex trafficking, have drug addictions, and they may accidentally or purposefully try to overdose. If you think about it, if you were raped 10, 15, 20 times a night, 6, 7 nights a week for months and months, and in some situations, years, um, I know I personally would start to look at drugs as a very viable option. The idea is to numb the pain and to help you forget. And if you're on those drugs, then you're going to feel less. That is why you're going to see a lot of those druggies that come in could potentially be trafficked victims. You may also see brands or scars, something that labels them as property. So if you see especially a name, if you see the same tattoo that comes in over and over on different girls in particular with sex trafficking, that's going to be a red flag for a group of trafficked victims. And of course, the abuse, the malnutrition. And it's important to understand that when someone is in the life of victimization and being trafficked, they don't really know that that's what it is. Many times they see their situation as I made a bad choice. I got myself into this because, well, I was taking drugs, or I needed a job and this is how I got my job. Some, especially foreigners, come from a life that is worse in many ways than what they have now. And so they just feel like, oh, you know what, I got a bad job. If I can just get through this, pay off my debt, I'm going to get a better job. And so they don't see themselves as a victim, and so therefore may not ask for help. Specifically for sex trafficking, very typical signs: the recurrent STIs, multiple pregnancies, frequent and many times forced abortions. Sometimes they could be beaten in the abdomen area to try to force that abortion, and then will end up in the ER miscarrying. I know one survivor who told me that she specifically had had 12 abortions while she was being trafficked. So when we say frequent abortions, we mean many times double digits. Moving around a lot, they may not know where they live anymore. They may not even know what state they're in anymore. And of course, clothing that's inappropriate because they want to be sexy. They're trying to get Johns to pay attention to them so that they can get the money that they need, because they typically have a quota, whether it be $500 a night, $1,000 a night, or they have to be with 10 men a night. Whatever it is, they have that quota to meet, so they're going to dress in order to meet that quota. For children and teens, you'll see them present with somebody who's not an adult. Locally, one dentist of all, we had done a presentation for some dentists, and it was reported back that because of a training that was done for them, they knew that when a gentleman called and said, hey, my neighbor is a teenage girl, I want to pay to have her teeth whitened, that raised some red flags. And sure enough, the gentleman was walked out because in handcuffs, because the dental office had the police there waiting for him when they got there with the young lady. So look for adults that are not a parent. Unaffordable possessions, the typical overfamiliarity with sexual terms, multiple partners. As far as the tattoo, most teens like to talk about their tattoos, so if they don't want to, then that could be a red flag as well. Attachment to the cell phone is a big one, and I know all teens are attached to their cell phone. In fact, a lot of adults are attached to their cell phone. But in the trafficking world, that cell phone is used to monitor them. Sometimes it is that they actually have it set so that the person in the waiting room can hear everything that is going on. So even though it looks like the victim is by themselves, in reality, they're being monitored from a distance away so they know that they can't say anything. It may look like they're free and moving around of their own will, but they're not. It's that phone is their tether. So some injuries, just like we have been referring to, neuropathy, scarring, fractures, basically a lot of trauma-related injuries, uh, being abused, beaten, tortured, those types of things are very common. Strangulation, so if you see petechiae with a line around the neck, uh, be conscious that that could be an asphyxiation, strangulation mark. Anogenital oral trauma. They tend to have a lot in the sex industry have issues with the neck and jaw because of oral sex. One survivor talked to me about that she was in a car and she was parked in an alleyway and the Johns were brought to her. Of course, she was all of about 15, 16 at the time, but the Johns were brought to her in the car and she was forced to perform oral sex 10, 15 times a night. And imagine what that would do to your jaw and your neck. So they're going to have physical injuries related to that. Some other health issues, again, have to do with the sanitation, infection, substance abuse, and mental health issues. Those are all very prevalent situations that they find themselves in. So when they do come into a medical facility, what is our goal? What do we want? Even if you have identified somebody as a potential victim, they need to be assessed for safety and for health needs. If they are not in imminent danger at that very moment, treat their health need just like you would everybody else. They came in for a reason, and so in order to develop that trust bond with them, you need to take care of whatever health need. If they're in pain, if they have an infection, whatever it is, treat the health need. If they are ready to make the jump to get out of the life of the trafficking world, then you need to identify any resources or referrals. And the social worker, case managers are probably going to be your best person to go to for that. For physicians, they need to determine if any additional testing should be done. If they're have been exposed to situations where they could have gotten STIs or an HIV exposure, are you going to prophylactically treat them for those infections? Chances of them coming back based on a culture result are next to none. So if you suspect they may have an infection of some sort, a decision needs to be made. Do you treat a probable victim based on a supposition versus waiting until the cultures are back? And that's something the facility where you work and the physicians need to decide if that's what they want to do. If somebody is under 18 years of age, then CPS needs to be notified as mandated reporters. We need to call them. If they are in their teen years, 14, 15, 16, 17 years old, then I strongly recommend that you don't just automatically call, that you have to let the victim know that that's happening. Otherwise, you blindside them and you totally lose any credibility that you might have, any trust that you might have built. They need to be involved in that. They need to know that this is a requirement. I have to do this. If they're over 18, then you need the permission of the patient before you can notify law enforcement. And chances are they're not going to want you to notify law enforcement. And we'll get into some of those reasons why they don't want that. But understand that if there is no immediate sense of danger, like you truly feel that they are not going to be shot dead in the parking lot, or they don't present with like a gunshot or a stabbing or something that is on that list of must notify, you have to have their permission. And if at all possible, you want to get them to report and not have the healthcare worker do it, because that has to do with control. So don't just automatically, oh my gosh, I think I have a trafficking victim, and start calling the police. That's not what we want to do. For those that are under 18, as a mandated reporter, you do have to report directly to DHS. Now, I bring this up because many healthcare workers or other mandated reporters think that they can just let their supervisor know, or the shift manager, case manager, that that's all right, I notified somebody, that's all I need to do, when in fact that's not true. At the bottom of the slide is the address for the PDF from michigan.gov, and you can read it all in its entirety there. But if your facility has a procedure in place where you need to notify social work or a supervisor, then yes, follow your facility procedure, but then make sure that the report is made, because as the person who has identified an abuse situation, it is your responsibility to make sure that that report is made. And once a verbal report is made, a written report has to be made within 72 hours. If you fail to make a report, there are civil and criminal penalties. But on the flip side of that, if you make a report and it turns out that a person is not being abused, then the criminal, you have criminal immunity from that situation, so you cannot be sued. Keep in mind that you only obtain enough information to make a report. As a healthcare worker, it is not your job to interview and to find out all of the details. In fact, that's a bad thing. If you push and ask questions, you could potentially lead them to answers that could get in the way of prosecution later. You can also potentially re-traumatize the victim and make things worse for them. So just get enough information, whether it be they say, yes, I am being abused, end of story, make your report. Don't work on getting details. Now, trauma in the brain. For those who are trafficked, obviously there is psychological trauma. What is trauma? The APA defines trauma as an emotional response to a negative event. Okay, sounds good. That trauma may cause physical and chemical changes within the body, which then will cause illnesses. So abuse, neglect, could be somebody who was in a hurricane, suffered a tornado, victims of war. It could be just watching somebody else get beat up. It could even be the death or loss of a loved one. Anything that causes an emotional response to a negative event. And if you look at it like that, human trafficking victims, they are abused many times before their trafficking experience. They've already been in foster care or residential care. Many of them have been abused prior to their trafficking experience. You've got poverty, sleep deprivation, forced drug addiction. There are many things that they experience that is considered trauma. And as a result, they end up with PTSD. The reason for that is with the trauma, the amygdala is placed on high alert, and the amygdala is the emotion center of our brain. It is the part of our brain that causes that fight, flight, or freeze. Now, until recently, I'd heard of fight or flight, but I didn't understand freeze. And it makes sense to me that the same part of the brain that makes you either fight your attacker or run away also puts your body into a full-on freeze. Think of the deer on the road who just stands there and looks at the car coming at them. Same type of reaction. They freeze and they can't fight or do anything. Um, so the amygdala is always on high alert and it starts to get bigger. Then the prefrontal cortex and the hippocampus, which is your logic center as well as your short-term memory area, then start to shrink. And some of the problems that come from that may not come out until adulthood, but if you think about it, you now are running on almost pure emotion. That fear draws a highway in the brain that leads directly to the amygdala. And so therefore the connections that are to the logic and the memory start to shrink and fade. So the person who experiences the trauma, especially if it's over and over and over again, they're constantly in fear, that amygdala becomes very enlarged. And there are many studies that do show this. So what does that look like when they come in to the healthcare setting? You now have somebody with a certain sense of immaturity. It may or may not be in a combination with moments of extreme maturity, difficulty controlling emotions, being very labile. Other times they may be very quiet and submissive, but the emotions are bigger and more pronounced than what you would typically see. Inappropriate sexual behaviors. You may see delinquent or antisocial behaviors as well. If you look at somebody who is constantly in a state of fear, they're, again, that fight, flight, or freeze. They're going to be over and above fighting whoever is trying to get them to do something they don't want to do, or they're going to shrink back and try to fade away. But it's the emotions that are really big. Those who suffer from the PTSD are also going to have relationship problems, and especially those who are in trafficking situations, because they are not allowed to socialize and have the normal nurturing and upbringing that the majority of us have the benefit of having. So they don't know what a normal relationship looks like. Everything is based on fear. And so their social interactions are just kind of odd and out of place. The poor tolerance for positive feedback, because they're constantly being told how bad they are, how worthless they are. They live with a large amount of shame that they can't tolerate being told that they do something good. They know better than to seek comfort or help from other people, because they're just going to be kicked. Even a dog or other pet, if they are beaten down enough, they're going to shrink away and they're going to quit coming to them, to anyone for, to be pet or given comfort. Instead, they're going to shrink away. Same thing for people. When abused enough, you quit asking for help. Notice if you have somebody that is constantly watching, you can tell something is going on. They're very on high alert, wanting to see everything, paying attention to every detail, but yet not engaging. Most people, when they're in a situation with others, they're going to banter, they're going to engage in conversation, small talk, whatever. But somebody who their life depends on watching those nuances of behaviors to determine whether or not they're going to get hit or they're going to get um, some other sort of trauma forced on them. They're not going to interact as easily. Victims of trafficking, especially sex trafficking, are going to have a view of themselves that is very distorted, very similar to those who come up with, say, they've been abused as children. Even though they weren't trafficked, the abuse situation and the trafficking situation, there are going to be a lot of similarities. So someone who's been trafficked, it's that whole why even dream about the future? There's nothing left. I'm constantly suffering. Every day is worse than the next, the previous day. Why should I look forward to the next day? They see themselves as very worthless, damaged. Shame is huge. Um, and they start to question whether or not they're going crazy, that mentally something is not right. And in many cases, due to the PTSD and depression, anxiety, maybe even some others like schizophrenia, those types of things may come into play as well. And when not treated for their mental disorder, they do feel that they're not right, but not sure why. And many times victims believe that it's their fault, that if I wasn't bad, this wouldn't have happened to me. If I wouldn't have done X, then Z wouldn't have happened. And many times victims, especially with sex trafficking, can develop a Stockholm syndrome or a trauma bonding, just like in intimate partner violence. And so they believe that their trafficker does truly love them and want to be with them. I just screwed up. And so I got beat because I did something stupid. Yes, I'm out prostituting, but it's because he loves me and we're going to get married someday. And I have to do this for a while now because then we're going to take the money and we're going to move away and have a beautiful life. And um, the traffickers they know how to manipulate, just like that cycle of violence in domestic violence, where they beat them down and then they have a honeymoon period where things are going great. See, he loves me. He wants me to be wants me to be with him. And so you develop that trauma bonding. But in the end, that manipulation just mentally wears them down even further. So when we identify somebody in the healthcare setting, now that we know what they look like, and we see somebody who raises the red flags and could potentially be a victim, now what do we do? So I've got a scenario here and I'm going to read through this, and I want you to think to yourself, how would you respond if you were the person in the emergency room when this victim came in? So we have a young pregnant patient who presents with bleeding and is visibly frightened. She only speaks Spanish and is accompanied by her brother who translates for her. He explains that his sister suffers from schizophrenia and has been refusing her medications for the last couple of weeks. He also states that she's had a few episodes of aggressive behavior, which has been directed at others as well as herself. So he's already come in and says, we have a mental condition, she's aggressive, she hurts others, she hurts herself. While the brother is talking, you notice there are bruises and puncture marks on the patient's arm, and the brother sees that you've noticed the marks and explains that the patient sells herself for drugs. At this point, you're kind of wondering about the brother, not so sure that he's trustworthy, so you request a certified clinical interpreter. Through the interpreter, the patient conveys that she is in the process of miscarrying and asserts that she does not have schizophrenia, although she does admit to feeling depressed sometimes. The patient's tone becomes increasingly desperate, and she explains through the interpreter that the man claiming to be her brother is holding her captive and giving her drugs. At this point, the man explains that his sister has long had delusions of persecution, and he discloses that she had required temporary restraints the day before after threatening family members while she was high on drugs. He suggested that perhaps this episode has fueled the current delusion. How would you respond in this situation? This is not a cut and dried situation. You've got somebody with obvious signs of drug use, somebody who appears to be very well put together and well spoken, who says that the victim has a mental disorder. She's tried to hurt herself, she's tried to hurt others, had to be physically restrained. Um, as she's getting more and more excited, not excited in a good way, but excitable and anxious and acting out, she's going to appear to have increased mental symptoms of a mental disorder, and she probably does have a mental disorder of some sort, whether it be PTSD, depression, anxiety. So in this situation, what do you do? How do you respond? So just kind of keep that in mind that there are, let's say 20 different people are presented with the same scenario. You'll probably end up with 20 different responses. And so this scenario just kind of points out how important it is for a hospital system to have something in place to direct care. You need an algorithm or a specific procedure to follow when somebody says that they could be a victim or the healthcare worker suspects that somebody is a victim of trafficking. When you do have a victim, you want to approach them gradually. Understand that somebody who lives in a state of constant fear is going to continue to be in fear. As a healthcare worker, you may be a good person, but they don't know that. And so they're going to be wary of anyone who's in their life. And so it's important that you be as non-threatening as possible. And they're going to be very keyed into potential judgmental attitudes. If, say, they've been on drugs, they've got an STI, things that people tend to make judgments about in our society, you want to avoid that. So crossing your arms or having a shocked look on your face when they explain something. You want to be very neutral, very non-threatening. Watch how you carry your body. Watch what you do with your arms. So pay attention to your body language as well as your verbal tone. You want to have an area that's very comfortable for them. If you keep them in a cold, sterile room, then they're less likely to let their guard down and explain what might be happening with them. So if at all possible, move them into a room where it's a little bit warmer and they're able to sit down and have a conversation with them. And of course, as we're always taught with therapeutic communication, you want those open-ended questions. You want to give them time to think about what they want to say and to say it. And don't just badger them with questions one right after another. Just sit down and have a conversation. The whole point of this is to develop a trust relationship. That is key to getting somebody to admit to victimization, is they need to know that the person who's approaching them really does care and that you can trust them. So now they've said that they're a victim. The next step is to make sure that they're safe. they got a safe place to go. Many times they're going to come into the emergency room and they're not going to have something that fits the requirements of admission. Sometimes yes, but many times no. So where are they going to go? How are they going to be safe? If you know that a person's with them that is potentially violent, you need to make sure you can get them someplace and hide their identity. Make sure that they get the medical care that they need. What other needs do they have? You know, housing, food. You know, maybe they haven't had a decent meal in a very long time. They need to know that they're entitled to that assistance, that they're not a burden to you, that they have the same rights as everybody else. And most importantly, they need to have control over what is happening. Give them choices. Let them run the show, not tell them what to do. They haven't had control over anything. And so once they have been identified as a victim, it's important to give them that sense of control over their life. Some questions that you could ask in a situation when you're having that conversation. You're not 100% sure they're a victim, but you can ask them, you know, about where they live. Do they know what city they're in, what street they're on? They might not know their street address. That's if they're moved around all the time. Um, Eat, sleep, and work in the same place. That happens very, very frequently. If they're locked into a hotel for days on end, or labor trafficking at a construction site, maybe they are forced to work and sleep right on the construction site. Can they leave their job if they want to? Um, any threats to them, their family, exchanging sex for food, shelter, drugs. And that's important for them to know that that is trafficking. Most of the victims don't see that. We call it survival sex, but it is trafficking. They're exchanging sex because they have no other way to get food or shelter, or if they're addicted to drugs, they will exchange sex for drugs as well. So it's not just money. And if they are not ready to leave the life, then ask them if they know how to get help if they need it. Um, so those are just some questions that you can ask. Obviously, that is not everything, but just to kind of get you started and make sure that you ask them in a conversation situation, not just rapid fire questions. If we look at reasons why they won't disclose that they're a victim, fear is by far the biggest reason for not disclosing their victimization. They fear that they will be injured, people they love will be injured. If they're from another country, if they come forward, they fear that they will be deported and sent back. Um, Maybe they have an arrest history. Maybe they have had a drug arrest or a prostitution arrest in the past. And if they tell you that they're being victimized, they'll get arrested again. Many of the traffickers plant and nurture this fear of law enforcement. So they are very afraid of law enforcement. They're afraid that they're going to be thrown in jail and they don't want to be there. They're also afraid of being sent back to their trafficker because if they do say they're a victim and they're not believed, then they can be sent back only to be beaten, abused, and potentially killed. Um, if somebody comes to us in the healthcare setting and we identify them as a victim but don't treat it properly and they go back to their trafficker, we could be sentencing them to horrific abuse, if not potential death. And I'm not saying that to be dramatic. I'm saying that that has happened over and over again. Other reasons for failure to disclose would be just that whole shame, especially if they're in sex trafficking, can you imagine facing somebody and saying, yes, I have sex with 10, 15, 20 men a night, and yeah, they drop that bomb on you, and imagine the shame that they feel that goes along with that. Um, so no, they don't want to share that. I wouldn't want to share that. Language barriers, obviously, that can get in the way. They don't know how to tell. So that's why it is so important to have a clinical translator available. Having that controller nearby and watching everything. Sometimes you have to be very sneaky about getting them alone and away from them, because if they can't speak privately, they are not going to disclose. And again, that distrust, that they don't know that there is another life available, and they don't see themselves as a victim. They don't know that what is being done to them is human trafficking. So just kind of recap what we went over a little bit earlier when we talked about trauma in the brain. Understand that behaviors in the clinical setting, that quiet person who avoids attention, but if pushed, may become very uncooperative or hostile. Because of that enlarged amygdala that is fueled by emotion, and their behaviors are fueled by emotion, can be very manipulative, especially when pitting healthcare worker against law enforcement, and vice versa. Um, and just like intimate partner violence, uh, it is very likely that when you see somebody, especially with sex trafficking, in the emergency room, they will go back to the life. They need, in order to get them to not go back, they need to build that trust. And sometimes it takes a couple of visits or multiple contacts with healthcare in order for them to feel like, hey, you know what, they really do care about me and it's okay. And like many teenagers, they may come across as very dramatic or needy. Um, so typically, if you look at this, and you think about the people who you may have come in contact with in the emergency room setting, what I just described is a patient that is definitely not one of your favorite patients. They're the ones that you're going to get stressed out with, frustrated with, and you just want to wrap it up and get them out the door as quickly as possible. So the next time you see some of these behaviors and you start to get very frustrated with that patient, ask yourself, why are they acting that way? It may be that they just had a bad life, whether it be abuse at home, whether it be abuse, in the community, or it could be human trafficking. I'm not saying that every patient who frustrates you is a victim of human trafficking, but dimes to dollars, you're going to find something in their past that is causing them to act that way. So now let's look at policy and procedures in the hospital setting. The first thing you want to do is you want to establish trust and confidentiality. That is a must. They will not come forward if they do not have that. You do want to make it a policy to see a patient alone. That is essential. And of course, utilizing trauma-informed, resilience-oriented, human rights-focused, and culturally sensitive approach for all of your patients. That is a huge mouthful. But the idea of trauma-informed care is that you assume every patient you come in contact with has had some sort of trauma in their life, and you want to approach them in such a way that you do not re-traumatize them. That could be as simple as when exposed, like they've got a gown on. Before you put your stethoscope on them to listen to their heart, ask their permission first, because they need to feel that they have control over their body. Otherwise, you could be triggering a response from them because you touch them without their permission. Just as simple as that. You want to collaborate with other colleagues who have been trained. Hopefully, within your organization, somebody will say, hey, this is a topic I'm interested in. I want to advocate for human trafficking victims. And so they go out and they start to learn more, and they kind of become the quote unquote experts of the facility. Learn who those people are and then collaborate with them and seek advice from them, so that when you do have somebody that you question whether or not they're a victim, you go to them and get their advice, and they can help you with what you should be doing. As a facility, partnering with advocates, other organizations outside of the hospital, as well as like your social workers, your case managers inside the health facility. Understand that as healthcare workers, we have the opportunity to identify and to initiate getting treatment, but the bulk of the response is going to actually come from social services and other organizations outside of the department. We're, as nurses, doctors, other healthcare workers, um, we're just going to barely put our fingerprint on the situation, and we're just going to be handing it off to the next available resource. And so you need to know who those resources are. Facility protocols. What is your facility protocols? If you don't have some, start asking about them. Get those who are in supervisor managerial roles, make sure that they're aware of the issue and start asking to have protocols put in place. That is the only way that you can know for sure how to handle a situation so a victim doesn't fall through the cracks. And then, of course, advocate. You want to become educated. You want to get training. You want to be able to advocate for the victims. And sometimes it might be the fellow healthcare worker who is extremely frustrated with that very difficult drug addict who came in the door for the sixth time in the last 6 months. Maybe you need to just remind them, hey, you know what? They could have something trauma in their background. Let's look at this a little bit more closely. Start advocating for the people that are very difficult to love and care for. But become educated and start looking for ways to help human trafficking victims. I want to wrap this up with the starfish story. Um, there was a older gentleman who was walking along the beach, and the tide had come in and deposited thousands of starfish on the rocky shore. As he's walking along the beach, he sees this young boy standing at the water's edge, and he's picking up the starfish and he's throwing them back into the ocean. One by one, he's throwing them back in the ocean. And the man's like, "Boy, what are you doing?" And the boy says, "I'm saving the starfish." The older man's like, "Son, there are thousands of starfish. You are not going to save the starfish. There are way too many." The young boy picks up a starfish and he looks at the gentleman and says, "But I made a difference for this one." And he throws it back into the ocean. He picks up another starfish and says, "And I've made a difference for this one." When we look at human trafficking, it can seem so overwhelming at the vast numbers, the millions of people globally who are being trafficked. And we need to just break that down and look at those that we can help. It is that one or two starfish that we make a difference to, and that's the one that you have to focus on. Here are some local resources for West Michigan, Muskegon in particular. Um, the These are numbers that you could call anytime, some websites that you may go to get information about human trafficking, or if you have somebody that you think might be a victim, you could call them. Every Woman's Place is a domestic violence shelter. They, with the Hope Project, frequently work together to uh, find shelter for women, and then the Hope Project frequently helps with counseling. Women at Risk is out of Grand Rapids. They're another good organization. And of course, Pregnancy Services can help if a sex traffic victim is pregnant. On the right side are some of the more legal aspects. The DJ Hilson is his office is also part of the task force and has some say into how we can help these victims. The Child Abuse Council, if you need to have somebody for interviewing, family support, that sort of thing. And of course, you've got the Lakeshore Human Trafficking Task Force as well as the Michigan Human Trafficking Task Force. On a national level, these are four big national organizations. The Polaris Project, or the National Human Trafficking Resource Center. It is very important that if you do identify anyone who is a potential victim, please report it to the Polaris Project. Even if you've already called the police department or the patient does not want to have legal involved, call the Polaris Project, because they are the ones who are in charge of gathering data. And it's through them that we're able to figure out approximately how many victims we have in the US. So please keep in mind to keep them in the loop. Also, if you don't know who your resources are, you can call them and say, hey, this is where I live, this is my zip code, what's available for me around here? So an excellent, excellent resource. And it's also a very easy number to memorize. So if you have a victim who's not ready to leave the life yet, 888-3737, 888. And try and get them to memorize that number so that if they get to the point where they are ready to leave, they have a number to call. And then of course I have my references. I want to thank you very much for listening, and I hope you were able to learn something. If nothing else, that this has stirred a desire to learn more about human trafficking, and I strongly encourage you to get on those websites and to do your own research and to learn as much as you can so that you can help victims within your healthcare setting. Thank you very much.